Thank you. I think because we are now approaching the stage of Q&A, so you can stay around, and we're not a big formal group. I think we can now start to ask questions to any of these. I would have one. Is there any estimate of man days or the development that is needed for some larger scale EHDS testing? Should we start to work on some kind of a roadmap? Because it is not going to be absolutely trivial exercise. We see that the tool is ready, that it does not need huge amount of improvement, but at the same time, we're only now starting to put together the sheer scope of what will have to be tested, how many vendors and so on. So would you have a rough estimate, rough figure?
No, not today. We will have to do the estimation, of course, and we are also in the two European project, IHE and IHE, and I think that it will be also a good way to have a first improvement test in order to after work on the estimation.
Okay.
Yeah. So yeah, and that's why we talk on the special session on this project how we can have a first demonstration during Vienna connection week of perhaps some improvements and alignments with some first requirements if we have.
Okay.
This is the idea.
Thank you. Any other questions? And maybe we can open the Q&A part now to all of the previous presentations from the audience. Because I think it starts to sink in the amount of work that is starting to be ahead of us, and Janos will still do the summary later on. I'm now putting together in my own couple of thoughts. If there will be some work required for the testing tool, and we start to have the timeline with Vienna week, it just shows more and more the need for the timeline, because every week and almost every day is now becoming more and more important than ever before. It is still manageable, but we really don't have that much time to waste. I was going to joke that it's great that we have the Connectathon this year in peak of June, because the nights are short and the days are long, and at least we'll have more productive days to work. But it is still only 24 hours that we'll have, and the amount of weeks is also not going to increase. So that's something we have to start to pay attention. Have you thought of any other questions to any of the speakers? And let's really have almost an open floor, because if we close this session now and then move over to the room outside and there'll be coffee, immediately would start talking. Then we drop this. We're sitting down and we are very formal, and I did not think of the question properly, so I did not ask. So I'll pretend that I sit through this 10 minutes and then hope Jan will release us earlier. So I'm not. And everyone got everything. So Janos, you can slowly start to put together your closing. Sorry. Oh yeah, this slide is. Is that a question?
For me, it's not a question. I don't want to make a question, I want to compliment.
Okay.
So that give more food for Janos to close. So the tooling is one thing, and okay, we have a very strong team, and I think we will deal with the tooling. And there is some more tooling already. So Sophia has gathered a version of Gazelle that we have managed to support already through different other projects. So there is things about lab reports, so people can even now start playing a little bit with lab reports, even with Fire. So there are things out there. They are not organized for the regulation purposes yet. So that's, but they will not. We won't have anything until June anyway. So you heard the Marcello's position. But that doesn't mean that we don't need to do something. I think we need to work also on other tracks, which are not only the tooling, is on the use case side. So we have made this multi-country working group on medical imaging, which potentially could issue some recommendations about how to structure use cases for the proper use of medical imaging. And maybe we need to think that we should probably start doing the same thing with other things. So we discussed in other sessions in this event and probably in other places that we invented patient summary in Europe, but in practice it's not included already in the daily practices. So how do you expect that doctors will use patient summary if it's not somehow included in their daily routine? So, and maybe we should think of, can we bring something to the community? I mean, the community of users, not the community of vendors at this stage. So there are other ideas that we need to think and open discussion points that will help also the joint action in putting some ideas there. Most of the people in our community, from users and vendors, they are in direct contact with real life implementations and use cases. And this is a strong point that, and maybe in the closed meeting of Friday, we could talk about these ideas, how to evolve this, because if you influence the use cases, you will influence the testing and the testing tools. I mean, you can do testing with a test plan with peer-to-peer and you don't even need test tools at the end. So we can even start testing the process without having the test tools at the beginning. So we need to think a bit about like that. I would also like to emphasize a little bit on the pre-registration process. So if there are new companies that would like to come to Vienna and experiment that have never come, maybe it's now the time to step up. And there is a group of people that will help you do that properly. So don't be afraid. We are not biting anyone, for sure. So that would be my recommendation, not only to work on the testing tools. The testing tools are pretty much in control. We have an innovation plan every year. So we have goals for 2025 already. We can modify them if something comes up, but that's not the critical point. The critical point is to find use cases that can be understood in real life, because at the end of the day, we are here to support the implementation projects somewhere around Europe. So it's not an academic exercise that we want to solve. So that's my idea.
Thank you. And I did not want to create the impression that Gazelle will be a bottleneck of that at all. On contrary, I'm not going to summarize the whole thing, but what did we learn? There is a demand, and I think for testing, there is demand for the testing process. The vendors themselves and some of the users want to have it. And I think that the problem with pushing EHDS in a successful direction, one of the issues is that not everything will have a customer. Not all of the parts of the regulation will have an immediate demand. So this is not an area that will be facing that challenge. The community wants it, the community needs it. With some alignments and some adjustments, they can fit it into, vendors can fit it into the life cycle. So I'm really not that worried about testing. There's other parts, and on maybe the selling, the advantages of EHDS, but that was not the core of this session. Janos, I will ask you now to come to the stage one more time and conclude and close the session. You might get 5 minutes earlier. You might get out 5 minutes earlier, and yeah, I think the floor is yours now. Maybe for that one go.
Looking at back at this session, my original thought is that I'll do a recap and summarize what has been said, but honestly, it has already been done, and it was not such a long session that would benefit. So I would like to talk a bit about my personal feelings about where we stand with EHDS, and specifically talk about some challenges briefly, because I think this slightly smaller group than we are in compared to the larger plenary sessions enables me to talk about these things that were not necessarily said on the main stage. So about feelings, in my opinion, I mean, personally, I'm very excited for EHDS. And the reason for this is that for a few years, I'm from Hungary. And for a few years in Hungary, something called National Health Data Space exists. National Electronic Health Data Space. That's the exact translation of how it's called, and it works brilliantly. I have, as a patient or as a family member of patients, have used this extensively and have saved lots of printed paper, lots of repeated tests, lots of inaccurate recollections of previous medical events, and also the healthcare providers that use the advantages of this health data space. They have had the opportunity to spend more time with me as a patient because they did not need to deal just with the sheer amount of paper that can be created for medical encounters. And this is something that in my opinion is key. Labor shortage in healthcare in all levels, doctors, nurses, allied health professionals, interoperability specialists, IT technicians, it's both a chronic and an acute problem that's probably not going to resolve itself in the way that magically more people appear in these roles, because that's just not the demographic and economic trends that we live among. So in my opinion, extending this great and efficient system which exists in Hungary, which exists in some EU member states, extending it across Europe, the same way that as 20 years ago or 25 years ago, if I crossed the border and I needed to make a phone call, I had to be worried, will it even work? Will they take away half my house for the phone bill for a cross-border call? Now within the EU, or actually a slightly broader area within the EEA, everyone forgot that these problems ever existed. You cross the border, your phone continues to work, you can make calls, you can send text messages, you can browse the internet, and you stop thinking about it. To me, the vision of EHDS is that if it's done right, nobody will have to think about EHDS on the user side, neither patients nor healthcare professionals. They will continue to interface, patients will continue to interface with their physicians, they will continue to interface with their health apps, hopefully more and more. Doctors will continue to interface with their systems, which are hopefully continuously improving in quality. And the only benefit EHDS will bring is that no matter where a medical event occurred within the territory of the European community, that data will be accessible. To me, this is the main benefit. Of course, this is not the only benefit. It's a great opportunity for creating a European single market for medical software. And to me, this is like the secondary benefit, and also bringing closer for the global vendors like GE Healthcare that I work at. It would enable us to create products that target a single market. For the local vendors that are currently active in only one country, it is an opportunity to expand, to have a better reach, and for those innovative applications which are currently many times not introduced in EU as first, but they are rather introduced in the United States or maybe China because partially because of the better regulatory environment, but in a large part simply because there is a single regulatory environment and a single market for a much larger population. EHDS is an opportunity to have them come to Europe. So due to this I'm excited. But I also would like to highlight that, as I promised, that I talk a bit about the challenges as well, but I will end on a positive note, I promise. That EHDS is not the first great European initiative. And some of these initiatives, like for example the reduction and then elimination of roaming charges, have been very successful. Others have had more mixed success. GDPR, maybe. In my opinion, the main risk with EHDS is that if it's done in a way where stakeholders are not pulling in the same direction, where already established methodologies are not used, and in a certain way maybe we are reinventing the wheel, then there is a big chance that it's more the burden part of EHDS that will be felt by member states, by vendors, by healthcare professionals. And if, in my opinion, we would miss a huge opportunity if this was the case. So if I have to say one key takeaway from this session and also all the other sessions that we've had so far, in a sense, is that the industry has a clear position that we have a proven way to achieve such interoperability. Overall, this procedure is called the IHE methodology, which has lots of elements. And even though it has in its name IHE, it does not mean that it is owned by IHE, in the sense that only IHE member organizations can utilize it. Everything that IHE produces is public good. The IHE methodology is a public good. And what I am asking all of you is to bring this message to as many people who are involved in the preparation for and the implementation of EHDS, is to leverage the public good that the IHE community is building, and the public good that the IHE community is continuing to build and improve for EHDS, to overall make EHDS successful. Thank you once again for being here.
Thank you very much, Janos. This concludes perfectly today's last session. See you tomorrow. Take care.